Hello everyone, my name is Kim from the Department of Urology at Ajo University Medical Center in Korea and the corresponding author of the article entitled Prognostic Significance of Preoperative and Follow-up Neutrophil-to-Lymphocyte Ratio and Platelet-to-Lymphocyte Ratio in patients with non-metastatic clear cell renal cell carcinoma. As the long title of the article implies, we try to investigate whether NLR and PLR that were measured initially before surgery and at follow-up at a certain point have the ability to predict future metastasis in non-metastatic clear cell RCC patients. Similar studies have been already published with patients with RCC at different stages, with different cell types, with different endpoints, and with different conclusions. Our study put more emphasis on follow-up NLR and PLR because it would make more sense to look at these values measured shortly before metastasis occurs and see if they can be used as an early sign of metastasis. So we performed a retrospective chart review and identified 309 consecutive patients who underwent radical or partial nephrectomy at our institution with at least 1 year of follow-up. Clinical pathological characteristics of our patients were typical, with mean tumor size of 4.7 centimeter and 2/3 being PT1 stage. At the mean 93 months follow-up, 44 patients developed metastasis, and we tried various cutoff values of NLR and PLR to come up with the best value that could discriminate those who had a significantly increased risk of metastasis from those who are not. The Kaplan-Meier analysis showed that patients with preoperative NLR equal to and higher than 1.7 were at significantly increased risk of developing metastasis. Also in the multivariate analysis, the same preoperative NLR level was an independent prognostic factor for metastasis, along with pathological stage, tumor size, and nuclear grade. However, we were not able to show PLR was an independent prognostic factor. Next, we calculated NLR and PLR values that were measured at the time closest to and before the time of metastasis. For those who did not experience metastasis, we used the median time from surgery to metastasis in the metastasis subgroup as an alternative time period from surgery in the non-metastasis subgroup. This time, patients with follow-up NLR equal to and higher than 1.9 were at significantly increased risk of developing metastasis, but it was not an independent prognostic factor in the multivariate analysis. However, I do not believe that NLR at recurrence is completely insignificant because, unlike pathological results that will have their significance diminish over time, NLR and PLR values at follow-up are dynamic and more relevant. So, if a patient with one or more adverse clinical pathological factors shows steadily high or sudden increase in the NLR value beyond the cutoff, this could be seen as a sign of cancer recurrence and a good indication to perform a CT scan. My conclusion is that NLR and PLR have prognostic values in patients with clear cell RCC, and their potential to predict patients' prognosis should be supported by many more studies in the future. Thank you for reading our article.